Welcome, everybody. My name is Adam Reyburn. I'm one of the intensive care physicians um, through QMG and Blessing. I was asked to speak on shock states, and so that's what I'm going to do. Try and I kind of obviously this is my presentation right here. It's well thought out, um, but I kind of it is the level of kind of what we're going to talk about is more probably like a probably school level shock. It's obviously more complex and 1 hour conversation. Um, Most of you guys practicing in a very kind of narrow environment in the ICU. This is going to sound pretty similar to things we've talked about in the past, even during rounds and stuff like that. But we'll start off with that. So the key thing with shock is to understand what it is. I mean, that's the first. If you don't know what it is, you're never going to be able to identify it. And because it's not hypotension. I mean, it can be hypotension, but it can be other things as well. So shock would be from a cellular level is going to be reduced oxygen delivery to the tissue, increased consumption of oxygen by the tissues, and or inadequate utilization of the tissue and those cells to utilize the oxygen it's receiving because of mitochondrial damage because of the poor perfusion. So if you want to remember anything about like physiology or pathophysiology today, it's shock's going to be tissue hypoxia leading to cell death, leading to organ dysfunction, organ failure is going to be the process of that. Why is it important? It's important because the shock has a mortality, at least in the setting of septic shock, is mortality about 40%. So the presence of it is an immediate risk factor for death, and then a 90-day risk factor for death as well. Um, it's always easier in my mind to kind of think of things as simple as possible. So when I think of shock, and we talk about tissue oxygen delivery already, but I think about it as the physiology. What are the principles? What are the driving factors for it? And so we mentioned blood pressure before, um, and blood pressure obviously is critically important. So if someone is hypotensive and hypoperfusing, that's going to kind of be shock. Um, so what generates blood pressure? Like what are the variables in our body that create a blood pressure? And really it's two things. It's cardiac output and it's systemic vascular resistance. So cardiac output is the LV function of sorts, how well is the heart beating, and systemic vascular resistance is how tight are the blood vessels. Are they dilated, like in distributive shock? Are they clamped down? That's what generates blood pressure. So if someone's markedly vasodilated, they're going to be hypotensive. If somebody's cardiac output's low, they're going to be hypotensive. So think about blood pressure as the cardiac output times the systemic vascular resistance, and that'll help you understand shock a little bit better. Now, what generates cardiac output would be the next question. So cardiac output is going to be, in physiology terms, is going to be heart rate times the stroke volume. So if you think about like cardiac output, if you're bradycardic, if you're in heart block, you could be in shock because you have limited, you have no pulse to generate cardiac output, as well as if your stroke volume is low, you could be having reduced cardiac output and shock as well. So stroke volume is going to be, let's say I cut my leg off and I got blood just spurting all over the place. My stroke volume is going to be low because I'm in hypovolemic shock. Um, the variables that affect stroke volume are pretty simple. It's preload, which would kind of be how much blood you have. It's going to be afterload, which is kind of that. It's really it's kind of systemic vascular resistance, and it's contractility of the heart. So if you don't have blood, or you don't have any contractility of the heart, you're going to have reduced stroke volume as well. So cardiac output, heart rate times stroke volume, and blood pressure being cardiac output times systemic vascular resistance kind of tells you all you need to know about really what generates blood pressure in the body. Um, that's kind of the mundane stuff about shock, to try to understand what is it at the basic level. Types of shock, right? So there's there are multiple ways to get hypotensive and in shock. Now, in the ICU setting, we frequently just see distributive shock or septic shock. That's about 60% of all causes for shock states. But there's other causes. There's hypovolemic shock. Again, if you are bleeding out because of a peptic ulcer, or you've lost your limb in an accident, that'll cause hypovolemic shock. Dehydration. We have frequently with people, nursing home residents, demented, can't get access to water, and they get dehydrated, coming with sodiums like 170, and they can be in hypovolemic shock as well. Uh, there's cardiogenic shock, which we don't see in the medical ICU as much, but obviously in the CVU you see it frequently. So cardiogenic shock is another cause of shock. Cardiogenic shock causes about 20%, and hypovolemic shock is another 20%. So if you do kind of the math, 60% is distributive and septic, 20% is going to be hypovolemic, and 20% is going to be cardiogenic shock, US wide. There are some other forms of shock which make up very small percentages of shock, like in the form of obstructive shock. So obstructive shock would be somebody with like a cardiac tamponade from a big effusion, or somebody with a massive PE. That's kind of defined as kind of obstructive shock. Those happen, but they're pretty unusual. So they're not a frequently seen condition. When you think of distributive shock, we talk about sepsis being the biggest causes. There are other sources for it as well. There's anaphylactic shock. So you get stung by a wasp, and you have sensitivity to it, have anaphylactic shock, vasodilatory shock. We'll see it occasionally in spinal cord injuries, where they lose the ability to control their vascular tone. So they get hypotensive, and maybe having some kind of distributive shock physiology. And then there's endocrine causes of distributive shock, like adrenal insufficiency. Again, fairly unusual, but things you always want to have in the back of your mind. Cardiogenic shock, the biggest cause of that's going to be somebody with a STEMI. So someone comes in with an anterior STEMI, their left main or LAD's down, and they have an EF that's very low. They could be in cardiogenic shock. There are other few causes of it, though. If someone has a STEMI and they have delayed presentation, we don't see this much anymore, but 25 years ago, delayed presentation for STEMIs, and they would actually have like left ventricular aneurysms that could cause shock, or they'd have the papillary muscle and the tendons that hold the valves onto the muscle get ischemic after a couple of days, and those things could rupture and cause shock as well. So those are that's a got an idea of like what are causes of shock and how we manage, or not how we manage it, but different things to look for. When you think of shock, it's important to know, like, what are you going to see at the bedside, right? So you make the assessment, they come up and they're hypotensive. Does hypotension mean shock? No. So how do I know what shock is? How do I know what shock looks like in the patient or the human body? And obviously, some of it is pretty easy to see. What's the blood pressure? Are they hypotensive? Obviously, that could be shock, and likely is. Are they tachycardic? Because most people, as a compensatory response to low blood pressure, to generate cardiac output, is going to be to increase your heart rate. And you should see that. But what if someone's on a beta blocker, or if they're on a big dose of toprol, or they have like a sick sinus syndrome, and they don't have the ability to really kind of upregulate their heart rate? They may not be tachycardic, but frequently you'll see them. We sometimes see people will come in and their work of breathing so hard, right? They're tachypnic. Tachypnea is going to be a sign of potential kind of shock, because they're acidemic and the body's response. If someone's really acidemic and the pH is low because they have a metabolic problem, the only way they can kind of try and neutralize their pH is to breathe off their CO2. You see this very frequently in our DKA patients. They're not in shock. They're very acidemic when they come in, and they're tachypnic. And we all say, oh, they're just anxious. Then they're really anxious. They're trying to breathe to save their life, and to try and normalize their pH. So then the problem is if you do sedate them, their CO2 starts to rise up, and the pH goes even lower. So you got to really watch these folks when they're really tachypnic. It's because it's a survival instinct to the human body. But also with that, you think about a lot of times these people come in and they're tachypnic, they're agitated, and maybe the blood pressure is not bad, but as the hours go on, we're saying, gosh, the work of breathing is too much. They're going to tire out here pretty soon. We need to have them on the ventilator. And what happens then? Put them on the ventilator, and next thing you know, their blood pressure, which was like 160, is now like 40, because the adrenaline that their body had coursing through the body was elevating their blood pressure. We sedate them, put them on a ventilator, take away their adrenaline, and now they're really clearly in shock, and hyperperfusing. When they were doing that before, but it was just kind of maybe unrecognized because of their level of agitation or work of breathing. So hypotension, tachycardia, tachypnea are big signs on the monitor of shock. Exam wise, and you can pretty much go from exam from head to toe. What's their mentation like? If someone's not in shock, they should be, and if they're not like overdose on medication, they should be talking. They should be interactive with you. If someone is unresponsive or very altered, that could be a sign of poor cerebral perfusion, which could be a sign of shock. So what's their mentation like? What's their skin look like, right? So skin's the biggest organ in the body. What does it look like? Is it has to give blood flow to the tissue for it to survive as well? So is the skin cool? Are they diaphoretic? Are they modeling? Those all may be signs of, or likely signs of shock as well. And then we always put a Foley catheter in these people. And what's their urine output like? So if their urine looks pretty dilute, it's not real concentrated, and they're making urine, that would be a sign that maybe that hypotension is not causing a massive shock state. But if you put a Foley catheter in, then there's nothing coming out. Again, that goes along with hypoperfusion and kidney failure as a sign of shock. So those are just simple things you can do to kind of look at the bedside evaluation of shock in my mind. Questions? You guys have any questions so far? What are you going to find on lab? So what are you going to see if you draw labs, or what labs do you want to draw to evaluate for shock? And most of this is pretty mundane stuff, but you're going to start off with a complete blood count. What's the value of a complete blood count? Well, if they have leukocytosis, that may go along with distributive shock and sepsis. What if the hemoglobin comes back at 3 and they're pooping blood out of their urine? Well, now they have hypovolemic, they're hemorrhaging. So that's can be a sign of shock that can help you out. Metabolic panel. How can the metabolic panel help you out? Well, the creatinine's elevated. That goes along with the problem. Frequently, people have ischemic hepatitis, right? They're in shock. They're hyperperfusing their liver. And so you see these liver enzymes that are in the 1,000 range. There's very few things that cause liver enzymes to go over a couple of hundred. So you start seeing liver enzymes in the thousands, and ischemic hepatitis is going to be the biggest cause. Acetaminophen overdose will do it, and acute hepatitis, like hepatitis A, can do that as well. So if you see liver enzymes that are really high, that's going to be ischemic hepatitis, which would go along with shock states as well. Obviously, it makes sense. You might want to check a troponin and see if that's elevated. Maybe that's an EKG. If the EKG shows anterior STEMI, probably have an idea this may be cardiogenic shock. Lactic acid, right? So we always check lactic acid. So what does lactic acid look for? It's kind of it's really looking at what we defined as shock in the first place: reduced oxygen delivery, increased consumption of oxygen by the tissue, and that's kind of that's what lactic acid is kind of really assessing. When you have elevated lactic acid, you're kind of going into overdrive. You used all your oxygen And now you're in the anaerobic phase of metabolism, and so your lactic acid will go up really high with that. And so anytime you see elevated lactic acid, that's a sign that maybe the tissue's not getting good perfusion. Now, unfortunately, not every lactic acid is shock, though. We frequently see the folks come in, maybe they have an asthma exacerbation and they're working really hard to breathe, or they're having a panic attack and they're working really hard to breathe. Um, those that excessive respiratory muscle use will generate lactic acid for the same mechanism. It's like you're running a marathon. So not every lactic acid is elevation of lactic acid is going to be representative shock, but it does say, hey, there's something going on. If you're perfectly healthy, you're not going to have elevated lactic acid. And so no matter what the situation is, it is something you want to look into, try to understand, at least define why do they have this. But definitely in the setting of septic shock or any form of shock, elevated lactic acid will occur. And the benefit of that really isn't in how high it is, but once you've identified that they have shock and you start managing it, you can use lactic acid and the clearance of lactic acid to say, how am I doing? So the lactic acid's 80 on the first check, and then you check a couple hours later and it's starting to go down, it's like 60 and it's 40. That's a good sign that they're getting better perfusion now than they were before. We frequently check a procalcitonin level. Procalcitonin level, it wasn't really defined and built to be a marker for sepsis or septic shock, though. What it was created for was to really define, do they need antibiotics? You see elevated procalcitonin levels in the setting of bacterial pneumonia frequently, or any kind of bacterial illness. And so in the world of like COPD exacerbations, it was kind of utilized, okay, if you have come in with short of breath and you're wheezing, everybody always got antibiotics. Then they kind of came up with the procalcitonin level and they said, if this procal is normal and your white count's fine, it probably isn't bacterial. We can hold off on the antibiotics and be more stewards of antibiotic utilization. So that's kind of where procalcitonin levels kind of came into being at. We've kind of used it for all different things now, and it can be used as a way to also kind of look for improvement in sepsis and septic shock. So if you check a procalcitonin level and it's like 100, you say, oh my gosh, it's high. What does that mean? Well, I'm already got them on antibiotics, so it means it's kind of jack deadly. But if you check it, a couple, next day and it's 40, you say, gosh, it's getting better. So, but you should also already have seen that because their shock state should already be getting better at the same time frame. But you can trend for calcitonin levels and see the improvement to a point in time to look for improvement in sepsis and septic shock. What I typically do is if I check it and it's high, then I'll check it for like 2 days. And if I start seeing it come down, I'll stop checking it. I don't have to see it go to normal, but I do want to see it come back down to a lower level. And that makes me feel good, I guess. Makes me feel warm inside. Other things you can do is obviously you're going to look for infectious causes, right? So you're going to do blood cultures, you're going to take a urine culture or urinalysis at least, chest X-ray that kind of covers your common infections, and you'll probably also get an arterial blood gas. We kind of mentioned this before, but an ABG is a very valuable thing. I know we're starting doing with EBGs as well. You get the same data from them, but arterial blood gas it gives you a lot of information about septic shock because of the bicarb level. We had a discussion recently from a more administrative level about like use of norepinephrine on PCU. And so do we feel that people on PCU should be on vasoactive drugs? That was kind of the question posed to everybody. And kind of the answer was that they felt no. If someone's on norepinephrine, they should be in the ICU. And I don't necessarily agree with that. I think you have to look at it. What does the patient look like? You got to go back to what the patient looks like. And if you have a 90-year-old lady, maybe from the nursing home, they weigh 90 pounds, and their blood pressure's like 85 with a MAP of like 60, and they may give them fluids, but they're still a little hypotensive, but their labs don't look bad, their kidney function's not bad, bicarb is normal, they can easily go to PCU on low-dose norepinephrine, and in probably in 4 hours, 6 hours, they'll be off of it anyways. And once you give them a little more hydration and volume, as opposed to somebody who comes in at ER and same blood pressure, and they've been given fluids, and then they get put on norepinephrine because they're still mildly hypotensive with the systolic under 90 or MAP under 65, but their bicarb is like 8. That tells me they're hypoperfusing. They're much sicker. And maybe they don't look too bad, but their bicarb is low. That's going to tell you they're a lot more ill. And so the ABG is really good in that setting, because if you get a ABG and their pH is like 7.3 and their CO2 is like the high 20s, because they're trying to blow off their CO2 to try and normalize the pH, but they have a bicarb of like 8 or 10 or 12, that person's sick. Biochemically, they're sick, and those folks probably do need to be in the ICU. So I think you can really look at the bicarbonate level as a way to really risk stratify who is septic and who's septic. And so if bicarb is normal, and they're not somebody who retains bicarbonate long term because of some breathing problems, then they're going to recover pretty quickly. Someone comes in with a bicarb that's low, hypotensive, being put on pressors, I would tell you right now that their prognosis is much worse. And so really use that ABG or that venous blood gas, or even just the serum bicarb, to really kind of gauge how ill they really are. So we've talked about how you define sepsis and shock. We talked about different types of shock, what you see on exam with shock, maybe how you evaluate shock. But what we haven't talked about is how you manage it, because that's the most important thing, right? And what interestingly, our management for it isn't always been the best. It's evolved, and I think we're doing a lot better job at it now. But historically, physicians have done a pretty crappy job of managing shock, because we try to just we look at the numbers and try to make the numbers look all normal. But in the setting of shock, I mean, you don't want to go to pressures too quick. You want to figure, okay, what is the source of it, right? So source control, identify what's causing it, and then manage the cause instead of treating numbers. But when someone comes into the ER, or someone comes over from a rapid response, and they're hypotensive, the first thing you got to give them is what you have on hand, which is crystalloid fluids, right? So we have plenty of normal saline, we have plenty of lactated ringers, so you're going to give them that up front. And so the data says about 30 mils per kilogram of fluid. So it depends on how big they are, but you're looking usually about 2 to 5 liters of fluid very quickly, not like running, through a small IV at 100 mils an hour, but we're talking like large bore IV dumped into them very, very quickly, a couple liters or more in the first hour for sure. So aggressive fluid resuscitation is your first thing to do. How do you get fluids, though? I mean, I always ask this question to medical students, and it's kind of interesting. People always say, well, a central line, right? And back in the day, it's like, I need a central line. They're hypotensive, we need a central line. Really, central lines are very poor for volume resuscitation. We say, what does that mean? They're in a big vein, but they're a long catheter. And so these veins are very, very long, 16 centimeters, 20 centimeters in length. And so they don't really fluid resuscitate somebody really well. Nowadays, with our vascular access team and what the nurse practitioners have been able to do with getting, good venous access with ultrasound technology, you really want like a 18 gauge IV. You want 2 or 3 18 gauge IVs. And if you can get those in place, you're going to give a lot of people a lot more fluid very quickly than you would with a PICC line or a central line. There's a physics law that looks at flow, and the longer a catheter is, or the shorter the radius of it is, it's going to create more resistance and impede your flow. So you want very small, very wide bore IVs when you fluid resuscitate somebody that's in shock. We got a lady in there today who came in. She had a perfed colon yesterday, and she has a cordis in. So cordis is just pretty much like a straw. They put a very small straw in her femoral vein, and you can give people a lot of blood, a lot of fluid very quickly with that. That's going to be your best fluid resuscitator from a catheter standpoint. And then once you're done with it, you take it out. You're done with it, put a triple lumen in or whatever you need to do. But cordis introducer would be a great way to fluid resuscitate somebody if you can't get peripheral access with big 18 gauge IVs. I mentioned to you before source control, and I think source control is probably the biggest thing in the world of shock. Again, you have to figure out what's going on. If they're if someone comes in and they're in septic shock, of course you want antibiotics, the right antibiotics as quick as possible, and that makes complete sense. But what if someone comes in with a UTI and they're in shock, but the source of the UTI is a kidney stone? They're obstructed from the kidney stone. But you can give all the antibiotics in the world, it's not going to fix the source of the shock. So you have to keep an open mind about what's generating the source fluid. If it's a pneumonia, sure, antibiotics. If it's cellulitis and it's not necrotizing fasciitis, sure, antibiotics. But you really want to make sure, at least from the sepsis standpoint, that they don't need to have to go to surgery, that they don't have a perforation, they don't have a bad gallbladder, that they don't have a kidney stone that's causing obstruction. So you always want to keep in mind, okay, what's the source of the shock from any causes? But you also want to make sure in the world of septic shock that you know where the source is coming from, and you kept an open mind about looking for different causes of it, like kidney stones, because kidney stones or UTIs don't usually make you septic that bad. It's very rare that we have somebody end up in the ICU with septic shock, real septic shock from a UTI. You just don't see that very often. So whenever we see somebody in the ICU with septic shock and it looks like it's a urinary based infection, doing a non-contrast CT scan of the abdomen pelvis looking for a stone, and I bet 50% of the time or more you're going to find it, because those cause people to get much more ill. So treatment for shock, source control, IV antibiotics early, aggressive fluid resuscitation up front. If someone's bleeding out, you don't want to give them saline. You can. You want to give them blood, right? So blood's the best volume expander we have. This is always a question I always ask medical students, but if you have a liter bag of saline and you give somebody all that fluid, how much of that stays in the vein? So of a liter of saline, how much of that stays in the vein? Anybody have any guesses?
About 300 mil.
Yeah. And Keith's right, about 300 mils. The pop cans have changed size, right? So I used to hold a pop can. Now it's not accurate, but this is 220 mils in it. But typically the standard 12 ounce can of pop is about 350 mils. That's all that stays in the circulation. So what happens with that then is you give somebody a liter of saline and 2/3 of it's going to end up in the soft tissue. So the next day when you fluid resuscitate them, now they're all anasarchic and puffy because they're full of salt in their tissue. So yes, we use it because that's what we have on hand. But once you kind of work through things, you want to either give them maybe some colloid like albumin if you're still fluid resuscitating them, or if maybe their hemoglobin's a little bit low, give them blood if it's appropriate, because blood is a very good volume expander. You give somebody a liter of blood, and about 950 mils that's going to stay in the vessel. So that's a much better volume expander than any other fluid that we have. What's the role for vasoactive drugs in shock? Well, if you fluid resuscitated somebody and they're still hypotensive, that's when you're going to want to use a vasoactive drug. What's the preferred drug for that? Typically norepinephrine is going to be your preferred drug. Historically, not as much probably in your guys' era of medicine, but when I was first kind of in medical school, they still use a lot of dopamine. And part of the reason was because we were so petrified of giving somebody vasoactive drugs through peripheral veins, small IVs, that they always use dopamine. So we'd have someone come in from Rushville or Carthage on a dopamine infusion. The problem with that is you guys probably see, dopamine causes a lot of tachyarrhythmias. And so these people may have better blood pressure, but they're also now at a heart rate of like 140. And because they're so tachycardic, they're not getting any filling of their heart. So they don't generate blood pressure because they're doing this all the time. You're not letting the chamber fill, generating blood pressure. And so dopamine has kind of gone by the wayside as a vasoactive drug for shock states, because of the tachycardia associated with it. So norepinephrine is going to be your first drug. If they're still in shock after that, there really isn't a algorithm that says you go to this drug next. But I would say that, for at least distributive and septic shock, that vasopressin is going to be your next drug you're going to go to. Uh, Vasopressin works on receptors like in the gut to improve blood flow. It doesn't really generate any tachyarrhythmias. It's not going to affect the heart rate at all. It's gonna improve the salt balance in the circulation, so you retain more fluid in the blood vessels, primarily. And so it's the second line drug. Now that's a fixed dose. So norepinephrine, you start at a dose and you increase it based on their response. Vasopressin is usually a fixed dose drug, so it's just like 0.04 units. You start off and you stay with that. You don't really increase it. Um, Other drugs for shock, you have epinephrine, which we've used some. Usually, when they get in that point in time, they're pretty darn sick. We have phenylephrine that you'll see out of the PACU, and anesthesia uses that. Phenylephrine is unique because it's just an alpha constrictor, so it takes your blood vessel from being dilated and squeezes it down. Um, it's a decent adjunct, but it's pretty weak blood pressure medication, so it's not used a whole lot. Um, and then you have sometimes the drugs to improve cardiac output, specifically like dobutamine, which we'll use in people with reduced EFs, or milrinone. You don't see much of that being used anymore, but milrinone can be used as well. And those are usually more utilized in people with cardiogenic shock, or maybe they have uh, some bradycardia associated with their shock states. Um, but typically, you can't go wrong with norepinephrine as your first drug. Um, Something that I'm not the best at, that you guys are probably better at than I am, is, and the last time I was going to kind of talk about, was how do you assess volume responsiveness? And this has kind of changed over time. Um, you start a treatment, fluid. How do you know that that's working? How do you know that that's helping? Because sometimes fluid can be harmful. You give somebody who's not volume responsive a lot of saline, and now again they get a lot of anasarca, they get a lot of tissue edema, they get volume overloaded, so they go into heart failure. So when do you decide enough's enough from a saline standpoint? And the problem is there hasn't really ever been a good answer to that question. When I was in training, um, there was a study that came out called the Rivers trial. And that was out of Henry Ford Hospital in Detroit. And that was really the first big study in septic shock. And that was called the early goal directed therapy for sepsis, if you remember that. And when they did that, what they used is they put a triple lumen in. That's where all put in central lines came from that. So they put a triple lumen in the right neck, and they would measure CVP. They would measure the central venous pressure as a way to kind of gauge that, they're plump, they're full of fluid now. So if you get your CVP to between like 8 to 12 or 10 to 12, you said, well, got their fluid resuscitated with saline. We're done with that. If they're still in shock, let's put them on norepinephrine now. The problem is that CVP measurements are horrible ways to really look at fluid responsiveness. What if somebody's got end-stage COPD, they got a big right ventricle because of pulmonary hypertension, their CVP is going to be really high at baseline because of the pulmonary hypertension. So but that's all we did for a while. But it's a poor way to do it. Then somebody said, well, you can do pulse pressure variation analysis. So you can put an art line in place and measure the pulse pressure variation with fluid, and see, with exhalation, inhalation, and see if they were fluid responsive. And it works very, very, very well. The problem is they got to be pretty much paralyzed on a ventilator to be able to get any real life data from it. Now, how many people want to be, that sedated or paralyzed on a ventilator just to figure out if they're fluid responsive? So it works well in somebody who's already in that condition. but you're not going to do that just to prove a point, so to speak. So pulse pressure variation with exhalation and inhalation, very, very, very good way to look at fluid responsiveness, or their volume or volume status. But again, it only works if they're deeply sedated or paralyzed and they're on a ventilator. Not real feasible in a lot of our patients. Then when I was finishing residency, the straight leg raise became popular. You raise, they have somebody in a supine position, you raise their legs up, and does that improve their preload? And does that preload improvement lead to better blood pressure? Was the whole theory on that one. And so that was actually used. I mean, the simplest damn thing in the world, passively raising their legs up and seeing that the blood pressure get better was actually one of the better mechanisms to look for fluid responsiveness. Nowadays, though, we have what you guys all call like the cheetah system, right? And what that's looking at is the Starling curve of fluid responsiveness to see, what's their real time cardiac output, what's their stroke volume variation with fluid resuscitation. And that actually probably the best thing we've had in my mind to assess that. It's not always 100% accurate, but it is a very, very specific test, meaning that if it's positive, meaning that you do that and it looks like they're going to be fluid responsive, then they most likely are going to be that way. Its sensitivity isn't as strong. It's not bad, but if it's negative, they still may be fluid responsive. But definitely, if it's positive, it kind of rules that in that they probably will respond to saline pretty well, or whatever fluid you give them. So that piece of equipment really has been probably a big game changer from a standpoint of assessing fluid responsiveness, in my mind. So kind of that's the biggest part of the talk I was going to give you. But the recap things, the key thing is identify shock. What is it? Who's in it? And so you have to understand, okay, what shock is. It's not just low blood pressure. It's hypoperfusion. It's organ dysfunction. How to real time assess at the bedside. What are signs of shock with their exam findings? What are the labs that I should order when I think of shock? And then obviously the most important thing is how did I start treatment for it? What are the key treatments? And fluids, the more fluids, still point. Pressures if they still are hypotensive, and then source control. If it's cardiogenic, I need to take them to the cath lab. If it appears like it's septic shock, they need source control, antibiotics and source control. And if they're hemorrhaging, that's the easiest one to identify. I need blood right now. And then if you remember one thing, it's IV access, big gauge IVs that are I always think big and fat are the best way. Then you want something that's that's a big gauge, and you want to say fat that it's short. And so those are probably the best ways to fluid resuscitate somebody. Don't think about triple lumens. Don't think about PICC lines, because that actually makes it even worse. Questions? Yep.
And the second energetic shock. Resuscitation.
Well, so the question was in people with cardiogenic shock, do you get them fluids or not? And someone with cardiogenic shock, it depends on like what type of shock it is. If it's an inferior MI, sometimes those folks will present hypotensive because their RV is down, and they actually are very fluid responsive. So if you get an EKG and the STEMI, they're in shock, and the STEMI is inferiorly, so like 2, 3 and AVF, they probably actually do need volume. If they're hypotensive and it's clearly anterior STEMI, they're not going to respond to fluids very well. And in those folks, you probably are going to you're going to give them something, because the thing that you have at your bedside is going to be saline. So everybody's going to probably get at least 500 mils or a liter of saline. But once you identify that that their cardiogenic shock is more of a LV failure, then you want to probably start more norepinephrine from there, and try and minimize their fluid. Frequently, though, we get this all the time that someone comes in with a history of heart failure. That so and so has a history of heart failure, so I didn't give much fluid. That's not right. I don't care about the history of heart failure. If they're floridly in heart failure right now, yeah, you might be able to sell me on not getting them a lot of saline or lactate ringers, but don't use the analogy, oh, they have a history of heart failure as a reason not to give them volume. Because what they need is up front is fluids for fluid resuscitation. And so I always cringe when I hear they have a history of heart failure. So I gave them 250 mils or 500 mils of fluid, because they need saline. Other questions? Not, we'll finish early. Class is missed. And
Gee, that's. It's a great part of the whole even break it for all the time, you know.
Okay.
I'm